Today we are covering spinal cord injury, a topic where knowing your priorities is absolutely critical for passing the NCLEX. When you see a question about a potential spinal cord injury, your first thought must always be airway, breathing, and circulation, with an immediate emphasis on stabilizing the cervical spine. Do not move the patient. The exam will test this with priority questions, asking for your first action. It is always to ensure an open airway and immobilize the spine. The level of injury determines the patient's functional ability and your nursing priorities. A key mnemonic to remember is C3, 4, 5 keeps the diaphragm alive. This is because these cervical nerves innervate the phrenic nerve, which controls the diaphragm. An injury at or above C4 is a catastrophic respiratory emergency. The patient will not be able to breathe on their own and will require mechanical ventilation. The NCLEX will present a scenario and expect you to identify respiratory arrest as the immediate risk. In contrast, a patient with an injury at T6 will have full use of their arms but will have paraplegia and be at risk for specific complications like autonomic dysreflexia. An injury in the lumbar region, like at L4, affects the legs and bowel or bladder function, but the patient retains full upper body and trunk control. The exam will try to confuse you between spinal shock and neurogenic shock. Spinal shock is a temporary condition that occurs immediately after the injury. It's characterized by a total loss of all reflex activity, motor function, and sensation below the level of the injury, resulting in flaccid paralysis. This can last for days to weeks. Neurogenic shock, however, is a life-threatening circulatory issue caused by the loss of sympathetic tone in injuries above T6. This leads to massive vasodilation, resulting in severe hypotension and bradycardia. The key difference is that spinal shock is about loss of reflexes, while neurogenic shock is about hemodynamic collapse. One of the most heavily tested complications is autonomic dysreflexia. This is a medical emergency that occurs in patients with injuries at T6 or higher. It's triggered by a noxious stimulus below the level of injury, most commonly a distended bladder or a fecal impaction. The exam will give you a patient with a T4 injury who suddenly develops a severe pounding headache, has a blood pressure of 210/120, is sweating profusely above the injury level, and has pale, cool skin below it. The question will ask for the nurse's priority action. The trap is to choose administer antihypertensive medication. The correct first action is to immediately place the patient in a high Fowler's position, sitting them straight up. This uses gravity to help lower their blood pressure. Only after sitting them up should you loosen any tight clothing and then quickly assess for and resolve the cause, usually by checking for a kinked urinary catheter or performing a bladder scan. Long-term management focuses on preventing complications. Because of immobility and sensory loss, patients are at extremely high risk for pressure injuries, so meticulous skin assessment and frequent repositioning are essential. Establishing a regular bowel and bladder program is also crucial, not only for the patient's quality of life, but also to prevent the triggers for autonomic dysreflexia. Remember these priorities, especially the immediate response to autonomic dysreflexia, as they are classic NCLEX questions that test your ability to act safely and effectively.